Good afternoon and welcome to our webinar on COVID-19 vaccination rollout. Where's the vaccine? Where's the patient? And who needs to know? Are we all following the data? We want to know how many vaccines are in the countries, where are the target groups, how many have been vaccinated, how many have received the first shot, the second shot, with what sort of vaccine actually. So we are all following, but in fact, this is all more complicated than it looks at the first sight, because overall, it's a very complex issue to monitor all these data and making sense out of it. And it's not only overall very complex, but the devil is also in the detail and makes it very difficult to communicate. And we come to the second step. How do we communicate actually how we make progress with the vaccination rollout? And today we have a couple of speakers actually that will fill us in on experience, first-hand experience from countries. And we have Cecile van der Koinenburg from the Federal Public Service, Health, Food Chain, Safety, Environment, well, the Belgian Ministry of Health. And actually, she has a lot of experience with emergencies and crises, as she was previously working for MSF. And she will fill us in how Belgium is trying to resolve the issues of collecting the data necessary and communicating it to stakeholders, the public, and experts. We've also today Frank Leisch from ELGA. ELGA is the Austrian organization which is organizing the electronic patient record. And I think it's fair to say that Franz has spent almost all of his professional life on the interface between digital and healthcare. So we will have here also first-hand experience of the data collection issue and how to pass it on to stakeholders and the public. And we have Joachim Ramsberg from Vaccination Sweden. He is project director at the Agency for Healthcare Service Analysis in Sweden. And last but not least, my WHO colleague, Sirdata Datta, who is the regional advisor on vaccine preventable disease and immunization. And you can figure that his services are in high demand at the moment. My name is Matthias Wismar, and I'm the program manager with the European Observatory on Health Systems and Policies. And I'm your facilitator today, and I will guide you through the program and the session. So the aims are today quite clear. We want to understand, what sort of data do we need to collect for the vaccination outroll? Do we need to collect new data? What are the instruments of data collection? And we also want to understand, how do we communicate them? What are the communication strategies? How are the targeted communication strategies for bringing the data to the people that need it? Just a couple of issues on the housekeeping. Our time budget is very tight, which is really a challenge for all the speakers. If you have questions and comments, please send them through the chat box. My colleague Erika will feed back the chat to us towards the end of the session, and your questions and issues will be taken up and discussed. We are also going to record the video, and we are planning to publish it on our YouTube channel. And finally, we will send you right after the session an evaluation form, and we will kindly ask you to fill it in, as it helps us to monitor the quality of our webinar series. This is the 15th webinar in a series, so please stay tuned and tune in again next week when we will be discussing long COVID, getting prepared for it. But before we start with the keynote, I have asked my colleague Erika Richardson to launch a poll on the topic. Erika, the floor is all yours.
Hello there. Annalisa, please do put up the poll. This is just something to warm you up, and also for us to get a feel for where the most important issues for you are. So the first question is, do you think your country's data collection and sharing strategy for vaccination rollout is sufficient? You can be absolutely honest. This is an anonymous poll. We don't actually know who votes which way. So yes, you think it's working well. No, we're having serious problems. Don't know. We haven't actually been in a position to test it yet. And then the second question is multiple choice. So you can choose between them. And that's looking at where do you think the big data challenges are in your country? So is it about identifying the right patients from different target groups? Are there issues around post-vaccination monitoring? Are there ICT capacity limitations? for example, is digitization an issue in your country? Data sharing challenges, granularity of the data, how much detail do you need, or all of the above? Okay, so you've got some time to get your answers back to us, but I'll hand back to Matthias. Thank you.
Thank you so much. So from the questions alone, I can see that there are many issues which can go really, really wrong. And I'm quite curious to see what the audience, what you are actually experiencing in your country. But before we go to the results of the poll, I would like to invite our keynote speaker, Cecile from the Belgian Ministry. Cecile, the floor is all yours.
Good afternoon, everyone. I'll be talking briefly about the Belgian vaccine rollout, and I hope over the next 10 minutes, I'll be giving you an idea on how we keep track of the vaccines, the patients or the vaccinated persons, and how do we communicate all of these data. Let me start by giving you a bit more information about our vaccination strategy. As you can see from the table, it's quite complex. Here in this line, these are all the different target groups that we identified and that we want to vaccinate over a certain period of time. All these groups have their specificities on the vaccines that they require, and each of these vaccines has their own logistical challenges. On top of that, all the target groups will be vaccinated in a number of different settings. So to compile all of that, we need a robust control tower, is what we call it, or a data collection system to make sure that we can keep the global overview. We started with nursing homes. That's still ongoing because we had some problems with long-lasting outbreaks. And we started vaccinating the healthcare workers in the hospitals. Last week, we've moved on to the first-line healthcare workers that are being vaccinated in the vaccination centers. And we will include collectivities that are related to health, such as homes for disability, persons with a disability. After this, it's the general public, but even there, we have different settings because they can be vaccinated in vaccination centers or at the workplace. So there's a lot of different issues to keep into account when we think about data collection. These are all the stakeholders that are at play in Belgium right now, but I would like to take this slide to illustrate all of the information that we are tracking. So this is where we buy the vaccine, where we deliver it, the additional material, and it ends up in a so-called hub. This is where we stock our vaccines before they could go to the vaccination centers. We needed special hubs for the Pfizer vaccine because it needs to be deep freezed. But these hubs will change over time as we will use more and more of other vaccines that have a bit easier storage characteristics. From the hospitals, they go to the centers of vaccination. This can be the nursing homes, the hospital themselves, or the vaccination centers, where we will vaccinate the persons, and this will be registered in an administration tool. So all of this information will end up in the control tower. The goal is to have a single source of truth. So this control tower needs to be very operational, and it's supposed to have a lot of transparency over what is going on. Who was vaccinated? When were they vaccinated? With which vaccine? How much do we still have in stock? What are the orders that we placed? What are we still expecting? And this is to feed the decision makers. This information is not made public, but it's transferred to the public health dashboard, which communicates with the public. And so the operational side and the public health dashboard, they feed on the same information, but the public health dashboard gets additional information to make sure that they can do post-marketing monitoring and surveillance. So they have to link up with lab results, with adverse effects, and so forth. The public health dashboard, it existed before COVID. We added all the information there. And for now, they're reporting on epidemiological data and on vaccine data. Our coverage is not high enough yet for them to interact with each other, But from the moment that we see that our vaccination has an impact on our epidemiological reality, these reporting mechanisms will merge and we'll have one report a week. As you can see from the previous slides, we have a lot of different data sources and a lot of different aspects that we want to take into account. In order to achieve that, we really try to go from existing data sources and existing tools. There was a lot of overlap with things related to testing because you also need to buy, stock, deliver. So we drew from lessons we learned there. We shared existing tools. For instance, our vaccine administration tool was already used in Flanders, mainly for childhood vaccination, but we made it public on a national level so that all regions can use the same tool and that everything remains coherent and uniform. We had to adapt this tool quite a bit because when we were moving from nursing homes toward other target populations, we noticed that we had to make some adaptations. For instance, in the nursing homes already, we had the issue that nursing home residents are vaccinated under the responsibility of the GP linked to this collectivity, but the staff is vaccinated under the authority of the occupational physician. So they didn't end up in the same data set, which is an issue that we had to resolve. Thinking about the strategy in the nursing homes, we will have to see if we have to change it, because now we're doing mass vaccinations in the nursing home. But when we have covered all of them, there will be new residents coming, but there will be much less people that have to be vaccinated. And we have to ensure that we will not have vaccine loss, because with Pfizer, you only have a certain amount of time to make sure you use all of the 6 doses. So we'll have to rethink our strategy when we evolve in our already existing strategy. Something that popped up was an issue with where we are vaccinating people. For now, the registration tool was monitoring coverage on the residency of the person that was vaccinated, but that didn't seem sufficient when we started vaccinating hospital staff. For instance, Brussels is providing vaccines for the hospital, for the healthcare workers, but the coverage numbers in Brussels were not going up because most of these healthcare workers actually live in Flanders. So we had to correct that. So now we're tracking not only the residency of the persons that are vaccinated, but also the region or the authority responsible for the vaccination. So there's all these little tweaks that we had to do to make sure that the system works in reality. We thought moving target groups would be an issue, but we managed to resolve this quite quickly by linking up the unique identifier and using the same anonymization key over different data sets. So this allows us to track one person throughout all aspects of the vaccination process. The thing that we're very much focused on right now are invitations, because we just started using our vaccination centers. So very likely that will have some issues. So we hope to find them as quickly as possible and to adjust wherever we need to correct them. To wrap up, I would like to highlight some good practices and some challenges that we're still facing. What I think went very well is that despite that we have regions, the networks across them work very well, and there was the willingness to collaborate. This allowed us to draw from existing data and to share tools and to make them available nationally when they were already available for one specific region. What was key was to have political support for our control tower, because it gives us a reason for existence and, more importantly, a voice. Often we have a great idea and then we ask ICT to realize it, but with a strategy this complex, ICT really needs to be involved from the start to make sure that whatever we want to do, that we can keep track of it. The scientists are happy with this distinction between a more operational data set and a more scientific data set to make sure that despite the political pressure, that we can keep a certain scientific rigor and that we can keep a public health view over all of this. We are still struggling with governance. It's not easy to know how we come to a decision and to know which decision is final. This is not only our reality for vaccination, this is basically the reality for the whole pandemic and all aspects that we need to tackle. The complexity of collectivities keep challenging us. There's still new problems or issues that keep on popping up. So we really try to be as conscientious about it as possible, but it's certainly a lesson learned that we have to try to simplify data collection systems and collectivities also outside of COVID. The final thing that we learned is the importance of ICT and that we need to include them in preparedness exercises in the future. This is my presentation. I hope it wasn't too much information on too short of a time frame, but thank you for your attention and I'm looking forward to the discussion.
Thank you so much, Cecila. I think that was a fantastic overview, and it also became clear this is a work in progress, that you continue to improve the setup while rolling out vaccination. And I found it quite fascinating to see the complexity just on one of your slides when you see the different target groups over different times, the different vaccines they get, and then in the different places. And even the different places are complex, as you said, that in the nursing homes, the patients get vaccinated by the GPs while the staff is getting vaccinated by the occupational doctors. And how do you account for this? And then the example from Brussels, where to assign the Brussels vaccinated but Flemish-based health workers is also quite interesting to see. And it shows that we always need to put the data into context, which is very challenging because it's almost real-time data. You need to publish them as quickly as possible. I also found it very interesting that you said we need to have this control tower, a single source of truth. But at the same time, on the last slide, you said, yeah, but we have sometimes issues with the governance, with the decision making, who's actually the decision maker. And I think that many people can relate to this. You know, Belgium is a federal country with a lot of co-decision making and distributed decision making, which is the case for many other countries. Thank you so much, Cecila. I think that was a great presentation and a lot of food for thoughts. And I'm quite sure that the spotlight speakers will pick up on this. But before that, Erika and Annalisa, can we have the poll results?
Hello there. So yes, the poll results are in. And very interestingly, there's a very even split between people who feel their countries are doing well, they're having problems, or that actually they haven't been able to test it yet. So hopefully there's a lot of scope for learning from countries that are already sort of rolling out mass vaccination programs. So when it comes to the issues that are being faced, one of the big issues seems to be the granularity of the data, getting enough detail. But there seems to be quite an even spread across all of these areas, which is no great surprise. And there are plenty of countries, plenty of places where it seems that all of the above apply. So yes, very interesting. Thank you very much.
Thank you so much, Erika. If I look at the first question, actually, it looks like, you know, some of the countries are still in a mess. Some have already pulled out, and some don't know yet whether they are in a mess or in good shape. So very interesting. Yes, it's now that I would like to invite our first spotlight speaker, coming from Austria, Franz. I'm very curious to hear your story. Please let me remind you that the time budget is, as said, very tight, just 5 minutes.
I can tell you something about the Austrian Vaccination Registry. I mean, there's so much more things about identifier, but that's like my project, so I can really give you details about that, and that's complicated enough. Maybe here. Just one slide about the Austrian Vaccination Registry. There was a long discussion about 20 years when we started. We started the project in 2018 by my company, the LG GmbH, which I'm the director of. And we plan to start it with a pilot with focus on the child vaccination program in 2020. but the COVID situation changed the pilot focus to influenza, because we thought it would be very feasible to test the system with the target groups of an influenza, and that we did that in October and November and December 2020. And we really then, pushed the system up for COVID, and now COVID vaccinations are mandatory to put it in the system, and the patients themselves can access it via the ELGA portal. It's like an online portal. We do not have an app yet. And what I need to tell you is that we had quite a challenge in the rollout, because by law we do not allow like a normal internet registration of the data. In Austria, only secure health networks are allowed, and we have a strong coverage of that, but not especially in those healthcare providers which do the vaccination and also the long-term care facilities. So we needed, to very shortly develop a secure mobile solution. That's what we started in summer. And what we did is we created a special vaccination tablets. The doctors love them because we developed them with them. And that we do not provide this Android app on the App Store, because it's like a bundle which we developed with the mobile network providers, like the big ones. And we have now about more than 2,000 tablets in the field, and that's like a strong, solid base for vaccination. But we also have integrated software tools, like we have about, at the moment, 2,000 places which already actively use the interface to our vaccination system. I know that that might be interesting. What are the minimum information we store about each vaccination in our vaccination registry? Like the date, information about the vaccinated person, the healthcare provider, and the vaccine with the lot number and the dose number, which is very interesting because the doctors were not used to that. They have to really choose dose 1 or dose 2, and that's a big problem. And there you see a tablet. If you later then share that link, you can see a video on there. It works like you take the tablet, you put it on your finger as a doctor because you identified on the doctor's list. Then you scan the e-card of the patient, and then you scan the data matrix codes, and it takes about 20 seconds to document the vaccination. And you can see that solution in the video, which is provided on the link. How much is the coverage of the COVID vaccinations? We generally can store any vaccination, but mandatory is only COVID now. We have about 97% of the vaccinations covered in the system, but you need to know that might be not that easy, because we have challenges with the data, because we have the delivery in district, and then we have the documentation, and the documentation links to the more to the patient where he lives. And so we have to place it like people who live in one district and but they work in another, and they're vaccinated in another place. So we really have you see different coverages, and we have regions where the organizations they didn't really put the vaccination in place, and so they really have to refill the system. And we also have the problem with the doses because some vials are 5, 6, 7, and we don't really in our system we do not monitor the waste. So we just know that was delivered and this is in our system, but I don't know anything about the waste. This is done by the local vaccination programs. We provide the data, real-time data, every day updated in the public dashboard. Where all the data is published for the public. We have also provided the link that we have all the open data. Anybody can load it down and do any analysis, but it's every day updated on real-time data, which is stored in our vaccination registry. And we have a second dashboard, which is like the watchtower, which is only for our internal use. And we see, we have about 500,000 vaccinations, COVID vaccinations now in the system, and we have 15 or 20,000 really wrong entries, and that's what we are, running after. We see a lot of wrong doses because the personnel is not trained well. We see that persons have 5 times the same vaccination. we have some lot numbers which were not available at that time, and we have the wrong dates. And what we now see, we need to do more training, and we really have to put filters like in the user interfaces or in the system itself. But that's like, it was so quick that we rolled it out that we should have made an evaluation, but we had no time for that from the pilot. But you've seen the data we have. What can you do with the data? Like the statistics and the vaccination rates, we really can do that very perfectly now on the data. As you see, we have 97% coverage. But the next steps will be like we can do efficiency monitoring of the vaccinations in real time, because we like in another place we have an epidemiological detection system, and we have the same keys, and we now will start to link the detection system. Like we even monitor there. Was it severe or not severe? I hope soon we will also have the mutants. So we very soon will be able to link our vaccination data to the epidemiological detection system and really get a real-time monitoring of the efficacy of the vaccinations. And the second thing will also, we have in the Social Security a medication database where we can now see, does somebody have diabetes or something, to see that in the medication, and we can link that data, and we will try to use that for monitoring the coverage of the risk persons. We're also trying to use it in contact tracing, and the last thing is, of course, vaccination certificates. We will use that in that, and maybe also provide for science, and that's all.
Thank you so much, Franz. Quite fascinating. Actually, you were just prepared for the right moment, and you switched from children to influenza, and now using it for COVID-19, and apparently, despite some little hiccups, quite effectively. I was amused to see that Burgenland has 118% achievement, while Tyrol only 75%, but I understand. But similar to the Belgians, actually, you say you need to have some sort of watchtower, and some of the data is just for internal use and for reviewing, and some you really can pass on to the public. And I see that you pass on quite a lot to the public. And I assume that this impasse is probably, this certificate is probably also important in the future when opening some of the lockdown restrictions. So thank you so much for this great insight. And without much ado, I would say we move to our next spotlight speaker, to Joachim from Sweden. Joachim, the floor is all yours.
Thank you. Okay, so first, just a reminder that we should note that healthcare in Sweden is heavily decentralized and run by 21 autonomous county councils. And so they are responsible for providing healthcare to the whole population. But there is actually a national vaccination program for children in Sweden, and all of those vaccinations are reported into a national vaccination registry. And this registry is now also used to register COVID vaccinations. And that registry is operated by the Public Health Authority in Sweden. And they have also been charged with distributing vaccines to all county councils in a centralized process, unlike how vaccines normally are distributed in Sweden then. And the Public Health Authority also issues guidelines and prioritization groups for the vaccinations. But it is the responsibility of the county councils to actually identify and vaccinate people. And in the registry, some very basic information is collected that I put up on the box here on the slide. And reporting into the vaccination registry is mandatory for all healthcare providers, and coverage is high. It varies a little bit, but for COVID vaccinations, it's very high. And one reason for this is that more than 90% of all reporting into the registry comes automatically and directly from the electronic health records. And initially, there was a little bit of an administrative hiccup as the interface most often used between the electronic health records and the registry is set to be abandoned and replaced exactly when the pandemic hit, in fact. And but this administrative issue has been managed for now. note that the vaccination registry is not the health record, and vaccination status of individuals is protected by strict secrecy. So there is actually no information flowing back to the electronic health records from the registry. The registry is used in similar ways as we've heard in Austria and Belgium, so that there is a control tower internally in the healthcare system and at the public health authority, but there is also a dashboard that is accessible to everyone in Sweden, which is updated with data on pretty much all weekdays. And we can have a look at that, right? Actually, I made this slide a couple of days ago, but as of February 19th, close to 600,000 people we can see had been vaccinated in Sweden, with a population of around 10 million people. And as can be expected, it's mostly in the very old age groups that a large proportion has been vaccinated, and in younger age groups it will almost only be people working in the COVID frontline. And I wanted to move on and say a few words about information and the willingness to be vaccinated in Sweden. And in recent polls, a large majority of people say that they are now willing to be vaccinated, but we note that different surveys show different numbers, and earlier surveys showed much lower numbers than this. And we have, as I said, there's been a large variation, and between 50 and 90% of staff in elderly care homes, for example, have been willing to be vaccinated. And to make sure that people make informed decisions about being vaccinated or not, the National Information Campaign is set to start this week, in fact. And there has been some political debate and some tension between the national and regional authorities about the late start of the information campaign and who is actually responsible for providing the information to different groups of the population. And in that respect, a particular concern is, of course, hard to reach groups. And there is certainly an anti-vaccine movement that is active also in Sweden. But I think perhaps more significantly, there are signs that certain socioeconomic groups are less inclined to be vaccinated than others. And there has been reports about fake news about vaccines, and we know from studies that people who rely on social media for information are more likely to hesitate to be vaccinated. And to counter this, some regions have started digital and social media information campaigns, and this has not yet been a concerted effort between the different regional health authorities. And so I think that will be a key issue as the vaccination will roll out. And I think that regions are pretty much set in terms of organization and access to data to roll out in the general population. And one of a key challenge that remains is actually the hard to reach groups. And I'm looking forward to continuing the discussion about this and other topics with all of you shortly. Thanks.
Thank you, Joachim. And I think it was quite interesting to see that the COVID-19 registration vaccination is building on an already established structure, which was there only for children, a national one. And even though there were hiccups, lucky Sweden that you have an electronic health record which is strong enough, robust enough to hold this data. And I understood from you all as well that there is clearly a need of a control tower, which is of course collecting all the information and data, but also then targeted disseminating this. Thanks a lot. And I would now like to ask my colleague Siddhartha from WHO to give us a couple of reflections on the presentations we've heard, and also maybe bring in some of the experience you have from the whole WHO European region. Siddhartha.
Yeah, thank you, Matthias. I hope you hear me well. Thank you, and it's really wonderful to be part of this discussion today. And listening to Belgium, Austria, and Sweden, one thing which I can definitely bring to this discussion as a starting point is that having diverse countries in the region with immunization and health system, which varies so widely from one country to another, this whole diversity is actually a strength of the WHO European region. The lessons that we are learning and the challenges that we are hearing from the countries who have moved forward with the COVID-19 vaccination is actually providing an element of considerations for other countries who are yet to roll out the COVID-19 vaccine, but also for those countries which have already started to see what are the challenges that need to be addressed moving forward. You know, a couple of things. One is that the COVID-19, the entire sheer scale of COVID-19 vaccination, number one. Number two, the time frame within which all countries are planning to roll out this vaccine. And then the complexity around prioritization of population groups, including the multiple vaccines that are being rolled out. In together, all these four elements would make COVID-19 vaccination and the data monitoring quite challenging. The vaccine characteristic, we heard it from Cecile in Belgium. They're considering what are the different elements they need to put in place. And the vaccine doses, now 2 doses, there are also vaccines coming up for single dose. So these elements are an essential part of what we say a data monitoring. But I think the other element which I also want to bring here, we heard that, is that preparedness was key and preparedness is key. Preparedness did not finish preparedness for this entire COVID vaccination, but also for vaccine monitoring. It did not finish with writing a strategy at the start of the rollout. We sincerely feel that this preparedness should continue, should be an ongoing activity. Review of the existing data or review of the existing strategy need to be done, and the strategy in its current form need to be revised as we move along. Some things which we thought would work today in terms of putting up the human resources, putting up a system to deliver the vaccine may have to be revised tomorrow. And this revision and the review of the strategy need to be data evidence based. And where would this data come from? These data would come from the country, as we have heard from all the 3 countries, that they are using their existing system to incorporate COVID-19, but also finding out avenues where these data elements could be strengthened moving forward. We see from the uptake and coverage monitoring, there are a few elements that we need to keep in mind as we are learning also from other countries who have rolled out. The in-country equity, or we say national equity of coverage and uptake by dose and by geography or population groups or the risk groups are extremely important. This will help the countries to also measure the extent the national policies had been fruitful to prioritize the risk groups and to reach out to these at-risk settings. All countries may not have the same structure. Even the high-income countries in our region have still had some teething problems in terms of reach out to understand the at-risk setting. And I think this was extremely important because the immunization program is reaching out in this compressed time frame and reaching out to a scale which the immunization program has never done. I think moving forward, there are a couple of elements that we would need to keep in mind while we are hearing as well the same thing from other countries. The role of safety monitoring, the role of disease surveillance, the role of vaccine effectiveness studies. These all are extremely critical elements in any decision making in the COVID-19 vaccine deployment and vaccination. The other part which we are hearing quite a bit, and we also heard that from Austria, was around the record or a certificate of vaccination. It's a personal certificate of vaccination. We have heard that for in several countries which have put either a paper-based or an electronic-based system, an app-based system has also come out through. So these are the lessons that we need to bring in, learn further, and see their use moving forward. The last part I would say would be that it is extremely critical that this data which we are gathering, it is being used for these review and revise process of strategy that we talked about, but also that data is tailored to a messaging based on the population groups that we are targeting. When we talk about this communication, we just cannot leave behind what Sweden, Joachim was mentioning about social listening and media listening, understanding the population's perception, because ultimately all these strategies are linked to reaching out to the population groups at risk or in at-risk setting. So these population perception should be an integral part of the numeric data on coverage that we are collecting. Understanding where our vulnerable population are in the country, population groups are, and then trying to find out, we ensure a national equity of the coverage is installed moving forward. So thank you so much, Matthias, for allowing me to reflect on some of the things, and then happy to contribute to this discussion moving forward. Over to you, Matthias.
Well, thank you so much, Siddhartha, for sharing your experience coming from the whole WHO European region, and this reaches really very far into the East. And let me just pick out one of the things you said, the preparedness is key. And if I understood you rightly, and I don't want to overinterpret and the presentations from the colleagues, it's actually this preparedness is integrated into the health system. We have seen like the Austrians, they have already started working on it, and then they thought it's for children, and they thought we change it for the influenza, but then they used it actually for the COVID-19, but they were already kind of prepared, and it was regular health systems. We heard from Sweden actually that they are using the children's vaccine record system, and the electronic health record, and that is also some sort of preparedness. And I think Cecile today, she didn't report on it, but the reporting adverse effects, the Belgians rolled out a system which was already working in the Flemish part, and they adopted it to the other parts of the country. So there's this already inbuilt preparedness which they use, which is not different from the health system. So thank you so much, Siddhartha, for this insight. And I hand back to Erica. Erica, I think it's now time for a little bit of discussion round.
Yeah, a little bit of discussion from the chat box. Please do keep putting your questions in the chat box, because I'm hoping we'll be able to squeeze in 2 rounds. So some really interesting points. One of them is around the speed of development, during the pandemic, and whether or not it's been possible to adjust course as you go along to address problems with reliability of data and things like this that have been identified and you talked about in some of your presentations. So how easy has it been to adjust course as you go along, given the speed of change? And also building on what Siddhartha and Matthias were saying, what about the challenges of repurposing existing systems, the challenges and benefits of doing that? And how can we focus on the accuracy of data input? And, were there any issues around, training or retraining of frontline vaccination staff to ensure data accuracy? And also some more sort of like fine detail points is, can people actually choose which vaccination they have? So are they allowed, the AstraZeneca or the Pfizer, et cetera, et cetera? And in terms of strategies for hard to reach groups, is there a particular issue around those people who are not actually in existing electronic systems? So people such as undocumented migrants, and whether or not there are strategies being developed to reach those particular groups. Okay, so over to you.
Yes, shall we start with you, Cecile? Just pick out the question which is most relevant or most easy to respond.
About being able to choose your vaccine, that's an interesting one because we have a hiccup with that. No, people are not allowed to choose their vaccine. It's like a scientific advice for each target group, which is most suitable. But we notice right now with the healthcare workers of the first line that they're not getting their vaccine because they hope that if they don't get it now, they can wait until the Pfizer is available for the bigger public. So they try to choose, and we're still thinking about how we will cope with that.
Yeah, so there were so many interesting questions, and continuing on Cecile's discussion, there is no choosing between different vaccines in Sweden either. And it is a bit interesting because we have already started to see indications of pretty high sick leave rates for staff who have been vaccinated with one of the vaccines. Up to a third of the staff is actually staying home because of adverse events for one or several days. So this is causing a real problem in some elderly care homes. And it's interesting that the people living in the care homes, they don't get at all the same side effects, but they receive a different vaccine. So I think there is some strategic issue here that perhaps would need to be addressed.
Thank you, Franz.
Oh, okay, I will pick the question about the validity of the data. You know,
Yes.
I mean, if you have like 15,000 wrong ones, like and 500,000, I mean, I think the dark number is much higher. But what we see from the challenge from, you know, boosting up a pilot with 30 doctors to a national system, you shouldn't do that in normal times. Definitely not. I mean, usually you should do that like a pilot with, I don't know, 50 doctors, then evaluate all the problems, you know, and we now, you know, while we are still rolling the system out, we already have working groups, how you make the, you know, correction processes, you know, who detects, you know, who is like trained to detect the problems, and how then gets the information back to the doctor, or who makes the corrections. And we do not have those, you know, process in place because, you know, we started with a technical pilot and we wanted to do that like in serious time. And this is definitely a problem because my whole team, we have no holiday, we have no day off. The weekends is more or less the days we only work 8 hours a day. And it doesn't really make sense to bring in more personnel, but because I couldn't train anybody, like my staff is well trained, we can do that, but we really need to focus on that. Yeah, and that's the thing. And at the moment, I mean, I would like to have more vaccines, but at the moment, it's not the baddest thing for the technical side that the vaccines are not running in like so much, because we have now time to establish the processes and to bring a little bit of quality in it. And because the more vaccines come, the bigger the problems get. And I really we don't only see the challenge of the COVID program because the politics said, the vaccination system works, so we want all the vaccinations in the system. So in reality, what's actually coming forward to us is that from March or from April, all vaccinations will be stored, not only the COVID ones. And then the dosage, you know, schemes are much more complicated. And we are now, how do we train the doctors? And the risk is when we now get all the crappy data in the system, how will we ever correct it? So from the tendency, if I could, you know, if any politician would listen to me, I mean, I say would, you know, I would say, no, you know, just, I mean, we're happy that we now get the funding. We were always say we need the funding, and now we get the funding. So, and I will, you know, I said, okay, now I get the funding, but I have a higher risk that the data will not the best one. And that's, we're trying to make all the correction processes. We train the doctors, we make webinars, we explain the doctors how to choose the right doses. So yeah, but it's a very tough and at the same time great time. Yeah, but you shouldn't do that like in normal times.
Thank you so much. But you know what? Sometimes I think having crappy data in the system is better than having no system in the no data in the system. And I'm getting tonight actually my regular tetanus jab, and I think there will be no trace in any system. So the data, please.
Yeah, thank you, Matthias. So I can contribute to the discussion around, the point Erica mentioned, the hard-to-reach population groups. And I think when we usually talk about hard-to-reach population groups, we have quite a diverse population group that we can define around this hard-to-reach. Often, and not so often, we have seen several population groups, the groups which is just outside our door also can become hard to reach because of one reason or the other. It's not always the physical distancing. It is not always the population group structure that makes it hard to reach. What we have usually seen in the routine immunization program, and then I think we need to keep on learning from that obviously the migrants and the refugees do constitute a significantly unreachable population due to one reason or the other. There are population groups where they do have access to the vaccines, but are not, accepting the vaccination as one of the preventive element. And I start usually with the healthcare workers, because most of the studies that we have seen, our healthcare professionals are sort of the gatekeeper in this COVID-19. They start being the recipient and then they start providing. So their acceptability within this COVID-19 vaccine is of paramount. And one of the questions in the chat box was around, how do we communicate this to the population groups that they are getting the vaccine? I think there needs to be a sort of a caution in the air here. The vaccine are being rolled out in the countries as part of the national strategies that have been put in place. If we are communicating to the population group at large, we need to communicate why they are not getting the vaccine now and when they would be getting the vaccine. Because if we provide a false sense of security to them, then I think there lies some degree of frustration within that communication, and the whole perception then changes. So we have to be a bit more cautious in this approach. However, it's not that we should keep them in dark, because they need to make an informed choice about, or they at least need to understand why my 19-year-old boy is not being targeted, why I or somebody else who is a healthcare worker is being targeted. Everybody needs to understand that, and they do understand this entire nuances. So the other part which I also want to bring out here is sometimes, and we are hearing it quite often now, that with the vaccination in the horizon is seen as a silver bullet to solve everything. I think that also need to be communicated very, in clear language, even to our healthcare professionals, to see that all other time-tested public health measures don't fall through the crack and we don't, lift our guard at this point of time. Over to you, Matthias.
Thanks a lot. Erica, do we have enough time for a quick round?
Super quick. Obviously, Joachim, people want to know which vaccine was potentially causing issues. I don't know if you can actually share that information, but, has it been reported to the EMA would be one of the things you might be able to share. And also, about the importance of monitoring adverse events, that's something that's come up in the chat box. And also building on what Siddhartha was saying, how can we communicate that? How can we communicate those data in a way that doesn't feed fake news?
It was the AstraZeneca vaccine who caused some side effects, and the residents had been vaccinated with the Pfizer vaccine, and so I think the hard to reach groups, I think Siddhartha made some really good distinctions there, and I would like to follow up on that discussion. And I think there are some indications now that you need to have a very open dialogue rather than just providing one-way information with this population. So, for example, a key piece of information has turned out to be that it's not mandatory to be vaccinated. You have a choice, and this is not forced on you, and you need to open up channels for discussions and asking questions to people that people like a GP or, trained physician in a chat room, maybe channels like that have proven to be quite useful in some pilot studies at least. And I think you need to approach this with an open mind. As I say, I think that's key.
Erika, anything else in the chat box?
No, nothing else in the chat box yet. But I think it's when it comes to communicating the adverse events. I wonder if that was something that Franz or Cecile would like to speak to, or if there. Oh, another question is about guidelines for healthcare workers who have been vaccinated. Are they treated differently in the system now with regard to their contact with high-risk patients, or is it still that all the protocols are still in place as they were previously?
For Belgium, for your second question, we didn't change any rules for vaccinated people, simply because we don't have information on transmission yet. So they have to still undergo testing and quarantine, but whatever results come out of their tests, that's taken, that will be looked under a microscope, of course, to check for vaccination efficiency.
Yeah, I'm afraid we are running out of time, and Cecile, we would like to give you the floor for a final 2 sentences. But before that, as I said earlier today, we have next week a webinar on long COVID, which should be very interesting. And from what I get from the discussion actually is that we need to have a webinar on fake news and infodemics. I think that's also very important. So Cecile, your final words for today, please.
Well, it's reassuring to see that there's a lot of similarities in all the vaccination strategies and a lot of similarities in the challenges. So I think it means we all try to do the best we can in the situation that we have, but we're not doing very bad. We're doing quite good. It's just that it's not easy. So my take-home message is we're doing okay, and it's great that we're learning from each other.
Thank you. Thank you so much, and bye-bye. See you next week. Bye.